Oh.
Just a second, it's not picking up the system. You'll have to ask questions later. Small wings. It doesn't want to let me access my Panapto. So if that's not a big deal, we'll just go ahead with lecture. Otherwise, give me a second, I'll get Panapto out.
That would be awesome.
Brian, got it? Yep.
It is not behaving properly. So we're just going to move on because we have a lot to cover. So we'll just, it's not functioning right. It doesn't like my new laptop. We are continuing with lumps and bumps today. Salivary gland diseases are not on your exam Monday, but our other category of lumps and bumps that are actually more common, the soft tissue lesions, will be on our exam. And one of the things that we are going to be thinking about as we go through and look at salivary gland diseases is, when do we think that a lump or bump in the mouth is salivary gland origin, and when do we think that it's connective tissue origin? So paying attention to those clues, even though this topic is not on your exam on Monday, will actually help you remember some things for your exam on Monday. So I hope it is helpful. So before we look at specific diseases of salivary gland origin, I want to review briefly the different types of salivary glands that we have and where they are located. So, gland A. What is gland? Come on, right?
Parotid.
What is A? Parotid gland. And what type of gland is it? In terms of histology, it's pure serous, which means it makes abundant, thin, watery saliva. And we have a surge of saliva production from the parotid glands during mealtime, so we can moisten our food, makes it easier to chew and swallow it, and actually starts the digestion process as well. So it's a pure serous gland. What gland is B? Submandibular gland. Physicians call it the submaxillary gland. It's like, what? I don't know where they got that idea, but no. Submandibular gland. And what kind of gland is it? Is it pure serous?
Mixed.
It's mixed. Mixed what?
Mixed
serous with mucus. So it's got some mucus secretions and some serous secretions. And we also get a surge of production of saliva from the submandibular gland when we have our meals. What is the name of the duct that carries saliva from the parotid gland into the mouth?
The parotid duct.
The parotid duct. It has another name too. You learned that in anatomy? No? Stenson's duct. Did you learn that?
No.
Stenson's duct or parotid duct, and the opening is the orifice, sometimes called the parotid papilla or extensins papilla, right in the cheek, opposite tooth number 3, or tooth number 14, our maxillary first molars, permanent molars. What is the name of the duct that carries saliva from the submandibular gland into the mouth? Submandibular duct? Did you learn the other name?
He didn't like telling us names.
Oh man, it is commonly called Wharton's duct. And the name for the structure in the anterior floor of the mouth where the ducts come from each side is called Wharton's papilla, or the caruncles, or submandibular duct papilla. So, and you know what gleeking is? Yes, so you gleek from your Wharton's papilla. My son can gleek on command. I cannot. What is C? The sublingual gland. Sublingual gland. So, sublingual gland, when you took anatomy, did anybody find the sublingual gland? Did you try to find the salivary gland? No? You didn't dissect? I find it very difficult to identify, but it's there. And it has multiple little ducts that empty directly into the floor of the mouth. There is another set of glands that don't show up here. And what are they? There's a name for them. Submental is a lymph node. Well, some people call your lymph nodes your glands too, but the minor glands. So what kind of glands are the minor glands? They're pure mucus. They don't make as much saliva, but they make that thick mucoid saliva. And what is its major purpose? To coat the mucosa, to protect the tissue surfaces. It really improves the quality of the epithelium. And where are the minor glands? Are they everywhere in the mouth? They are mid to posterior, hard palate, soft palate, and pretty much everywhere you have movable mucosa. So it's probably easier to say where you don't have the minor glands. And there are 2 places you do not have the minor glands. Only 2. Gingiva, a place near and dear to your hearts. Tongue has minor glands. Even dorsal tongue has minor glands, just not as many. So there's one other location.
Hard palate.
Anterior rugated hard palate. Everywhere else we have them. So knowing where they are helps us have some awareness if there's a lesion present in those areas that maybe it could possibly be arising in salivary glands. So we have a lot more salivary glands in the mouth than a lot of people realize. And we can have a variety of different problems with them. We divide our problems into 2 broad groups. The neoplasms, which are both benign and malignant. We're going to study a whole bunch of them. Unfortunately, there are a whole bunch of them. And then the things that aren't neoplasms. Which do you think are more common, the non-neoplastic disorders or the neoplastic disorders of salivary origin? Non-neoplastic disorders are far more common. So even though we have fewer of them, they're the ones that you're going to see more frequently. Regardless of whether we are working with neoplastic or non-neoplastic disorders of salivary gland origin, there's really a limited number of ways that they can present clinically. Single most common sign of salivary gland disease is swelling. So we can get swelling because there's a tumor in the gland, but we can also get swelling because there's inflammation or there's obstruction of salivary outflow. So all kinds of things can produce swelling. A close second sign, which is also a symptom is pain. So many of the things that occur will present with pain. But not all of them. Sometimes we have painless disorders in our salivary glands. And lots of reason for pain. Obstruction, infection, neoplasms. Another manifestation, a possible manifestation of salivary gland disease is dry mouth. Another term for dry mouth is xerostomia. We are going to talk about xerostomia, at least briefly. But the one thing I want you to be aware of is that the overwhelming majority of times that a patient has dry mouth, it is not because of salivary gland disease. The salivary glands are healthy, but they are not getting properly stimulated to produce saliva. Does that make sense? So when we have patients who have dry mouth, they have to be pretty carefully investigated to find out if the underlying problem is in the salivary glands or somewhere else. Sometimes patients who have salivary gland disease have taste abnormalities. If you have an infection in your salivary gland, we get acute inflammation and pus production. Pus gets excreted, purulent exudate gets excreted in the saliva, and that causes a bad taste. A lot of patients describe it as being salty. A salty taste or a bad taste. Sometimes it smells bad too. Some patients complain of a metallic taste in their mouth. That is rarely because of a problem in the salivary glands. That is usually a metabolic problem. So metals are being excreted in saliva, but the problem is not native to the salivary glands. But occasionally metallic taste is, not very often. One of the least common clinical signs of salivary gland disease is sialorrhea, which is exactly like what it sounds like. Excess salivation. Most of the time, excess salivation comes from a problem outside the glands, that there's inappropriate stimulation of the glands, not really a problem native to the glands itself. Question?
For the metallic taste, is that also in part to medications the patient might take?
Sometimes it's from medications. Sometimes it's because of kidney disease and inability to excrete toxins. So they end up being excreted in saliva and we taste them. Sometimes it's due to metabolic diseases that do some weird things, but occasionally it's due to medications. Often it is not, but it can be. Question? Sialorrhea, it means excess production of saliva. It's like diarrhea of your salivary glands. Overproduction of saliva, which, as I said, is usually not a problem native to the salivary glands. One of the interesting things that I have noticed over the years, I have patients that come to me in my clinical oral pathology practice with a chief complaint of too much saliva. I have too much saliva. Almost every patient that has ever come to me with a complaint of too much saliva, when we objectively measured their saliva production, it was actually reduced. So patients' perceptions are often very incorrect. One of the things that leads to a perception of excess saliva is drooling, which can be an age-related thing. As we age and we lose tone and collagen in our subcutaneous tissues, the face drops. The corners of the mouth drop. There's a reason people have facelifts, got to pull things up again. But when the corners of your mouth turn down instead of up, it creates a nice channel for saliva to leak. And it happens a lot. Another thing that contributes to drooling and a perception of sialorrhea is when the saliva is thicker than normal, which is actually part of dry mouth. And patients have to more consciously swallow their saliva. They're more aware of it because it's thicker and doesn't swallow as easily, and they think they have too much, when actually they don't have enough. So it's very interesting that a lot of times patients' perceptions are not on target with their actual signs. So we have to evaluate these things very carefully. We start with taking our history, but then we take some objective information as well. So we're going to move into our specific diagnoses. The first one we're going to look at, or the first group, are the non-neoplastic things. And we are going to start with the common mucocele. The word mucocele is best used as a descriptive term like leukoplakia and speckled leukoplakia and desquamative gingivitis, because there's more than one thing that can have this clinical presentation. It is strongly skewed to one thing, and so some people do use this as a diagnostic term, but I will not let you get away with that. So you should use it as a clinical descriptive term, and it is a clinical descriptive term for a swelling in the oral mucosa that appears to be due to the collection of salivary mucus. So if there is a swelling that looks like a collection of saliva in the tissue, the clinical descriptive term for that is a mucocele. Muco for mucus, cele for the swelling that it creates locally. By far and away, the most common diagnostic entity, true disease process that presents clinically as a mucocele is a mucus escape reaction. We'll talk about that in a moment. But some of them are mucus retention cysts, and on rare occasions, they are actually neoplasms that produce a lot of salivary mucus. But most of them are mucus escape reaction, and that's why some people get really lazy and just use mucus escape reaction interchangeably with mucocele, but I won't let you get away with that. It's a dangerous trap, because as soon as you use them interchangeably, you forget that it could be something else, and the something else could be significant and maybe needs to be managed differently. So let's talk about mucus escape reaction. I love the name of this disease because it's very descriptive about what the disease process is. Could I have the talking in the back stop? It's very distracting to me and the people around you, so it needs to stop. Thank you. Mucus escape reaction occurs when we have damage to a salivary duct, major or minor. So there's rupture and we have saliva that's flowing directly into the tissue. And so the mucus, the salivary mucus, is escaping into the tissue. Where is the saliva supposed to go? Into the mouth. So it's produced by our Asner cells. It's dumped into the ductal system and dumped into the mouth. And it is always supposed to be separated from connective tissue by a barrier. And it is actually perceived in the tissue, once it gets into the connective tissue, it is perceived as a foreign protein because it's not ever supposed to be in connective tissue. It's supposed to have a barrier between. And because of that, it produces a tremendous acute inflammatory reaction. And the body tries to contain it and eliminate it because it's foreign and it should not be there. So when we have this mucus that flows into the tissue, two things happen. We get a lot of inflammation, so we get infiltration of the area by neutrophils and macrophages, and they are actually phagocytizing the mucus. The pink stuff is the salivary mucus, and breaking it down and trying to get rid of it. But we also try to repair and contain it. So we grow a layer of granulation tissue around the pool or puddle of mucus that creates kind of a barrier between it and the rest of the connective tissue. So we get this puddle of saliva that's surrounded by a wall of granulation tissue that's very inflamed, contains a lot of neutrophils and macrophages. When we look histologically, we can usually find the feeder duct that's been ruptured, and we can usually find the feeder gland nearby, and it's going to show a lot of inflammation because of back pressure. We get back pressure when it can't dump out properly. So histologically, we see some very distinctive types of changes. Clinically, patients often remember the traumatic event that caused the rupture of the duct. They may not know what's going on in the tissue, but they remember that they traumatized their tissue and then a swelling developed. So are you going to traumatize your tissue and then the swelling develops 6 weeks later? No, it's right afterwards. So there's that close time association. And our mucus escape reaction develops very quickly, a matter of hours or days after the traumatic event. They have different appearances depending on how deep they are. If they're very superficial, we tend to see a translucent swelling because you can actually see the fluid right under the surface. If they're a little bit deeper, they tend to be a little bluish because they trap the light. But they're going to be a small, usually localized, fluctuant swelling when it's a minor duct that's ruptured, and a large swelling if it's a major duct. We tend to see mucus escape reactions in locations that are easily bitten. So biting trauma is the most common cause of rupture of the salivary duct that produces a mucus escape reaction. So common locations are going to be that wet dry line on the lower lip, because it's easier to bite the lower lip than the upper lip. Have you ever tried to bite your upper lip? Actually, you've got to work at it. So we hardly ever see mucus escape reactions on upper lip. If we do, it's an older person who has a longer upper lip than a young person. We can see them along the occlusal line on the cheeks, and we can see them along the edge of the tongue. Those are common locations because those are common places to have biting injuries. Sometimes patients will tell us these lesions swell up bigger at mealtime, and then they slowly shrink down between meals. Does that make sense? Because you produce more saliva at mealtime. So that's a common thing we hear. Another thing that we hear is that patients play with them. They poke them. Yes, they do. And they tell us things, oh, I poked it and it drained out clear fluid. Or I bit it and it drained out clear fluid because it was bothering me, so I just bit the top of it off and it drained out clear fluid, but then it came back. That's a typical story that we hear for mucus escape reaction. So the rapid onset, fluctuating size, drainage of clear mucus, if they pop it, those are common things. The vast majority of time, these do not self-heal. Occasionally, the super superficial ones will reconnect, reestablish the duct connecting with the oral mucosa and drain properly. But most of them just keep draining into the tissue and producing inflammation and bigger swellings that pop and drain. So the best treatment is surgical excision. And surgical excision needs to include not only the swelling, where we have the puddle of mucus in the tissue, but also the feeder gland. If you don't get rid of the feeder gland, the problem recurs. So normally the surgeon will do a little elliptical excision of the top part, kind of open the surgical bed and pluck out the little minor glands that he or she can see to make sure all the potential feeder glands have been eliminated, and suture it closed and everything is good. So that works very, very nicely. Who is the best person to treat this? General dentist or a surgeon?
Surgeon.
Usually a surgeon. These do have a high risk of recurrence if you don't get all the feeder glands out, and so it's usually better to have an experienced surgeon remove these. What if the patient says, I want to just wait and see if it heals on its own? You can do that, but they almost always come back and say, I'm tired of it. Okay, you win. I'm ready to have it removed, because they really don't self-heal. We're going to go ahead and finish this one, and then we'll take our break because these are closely related. So the much less common thing that can present clinically as a mucocele, a swelling due to the collection of salivary mucus in the tissue, is a salivary duct cyst. So a cyst is a sac of fluid lined by epithelium. Mucus escape reaction is a sac of fluid. Why isn't it called a cyst? Because it's not lined by epithelium. So the difference between mucus escape reaction and salivary duct cyst is that salivary duct cyst is lined by epithelium. What we believe happens to produce the salivary duct cyst is that we have minor trauma, usually a crushing trauma or maybe trauma from a stone in a duct, that causes damage to the inside of a salivary duct in a way that it seals off but doesn't rupture. So the gland is still making saliva, but it can't get out, so the ductal system just dilates like a balloon to accommodate the saliva that's being produced. And thus we get a cyst. So we call it salivary duct cyst because the epithelium that lines the cyst is the ductal epithelium from the salivary duct. So it makes sense. Doesn't that make sense? One of the interesting things that we see is that the salivary duct cyst usually occurs in locations that are not easily bitten. So biting trauma tends to produce mucus escape reaction in those locations where it's easy to bite. And the types of minor trauma that seal off the ducts, producing the salivary duct cyst, tend to occur in other places. But other than that, they look about the same. They're usually small swelling that is translucent. You can see some fluid in it, and if you palpate it, you can feel the fluid movement, so it's a little bit fluctuant. These usually have gradual onset. Patient usually does not recall the traumatic event, and they enlarge very slowly in comparison to the enlargement of a mucus escape reaction. Patients don't tend to poke them and drain them either, because they're not as obvious locations. So, the one on the left is my favorite one. This was a dental student, a second-year dental student at USC when I was a resident doing my specialty training. And USC, like Loma Linda, students take oral pathology their second year. And like Loma Linda, salivary gland diseases is way at the end of the quarter, way at the end. This dental student found this lesion on his posterior lateral tongue the night before his midterm. And got really worried and studied all kinds of worrisome things, hadn't gotten salivary gland diseases, had no idea what this could be. And he actually insisted on an oral path consult before he would take his exam because he was so worried. So we were amused by that. This picture was taken by pulling his tongue as far forward as we could. But even so, I think you can see that this lesion is actually posterior to the last tooth. There is absolutely no way that was caused by biting trauma. Now, I don't know how you would do any kind of trauma to that part of your tongue, but he managed to, and when you shine a light on it, it's translucent. You can see it's clear. So it was salivary mucus, and when we removed it, it had a ductal lining epithelium, so it was a salivary duct cyst. And it was removed and treated very, very easily. So that was kind of a fun one. Have you learned anything else that kind of looks like this with prominent blood vessels on top? Lipomas. Are lipomas common in the mouth? Even the uncommon salivary duct cyst is more common than a lipoma. If you shine a light on a lipoma, is it going to be translucent? No, it's going to be opaque. It's going to be opaque. So sometimes you can see translucence in a picture and sometimes you can't. So you have to pay attention to the story. If it's translucent but you can't see it at all, we'll usually tell you. So you shouldn't have trouble distinguishing these from lipomas in real patients. This is an older adult female who had a small swelling down in the vestibule. Can you bite your vestibule? No. It's nowhere near the occlusal plane. Can you see the translucence? Can you kind of see how the light glows through it? I might not have to tell you this one's translucent, but that one ended up being a salivary duct cyst. Do you see the lesion in this patient?
Yellow.
Was it that one?
Yeah.
Actually, I think it was the one anterior to it. I think it was this one. But anyway, it was one or the other. But it's very small and more palpable than visible. So when you do your oral soft tissue exams, do you palpate in addition to look?
Yes.
Good. You did find it. So those were examples of salivary duct cysts. Not very common. Also treated by excision. Doesn't usually recur. Has a very low recurrence rate. Usually easier to find the feeder gland and get it out too. So those do very, very well. This is a good place for us to take our break. So we'll take a 10-minute break and then we'll come back and finish our discussion of salivary gland diseases and all.
So Dr. Richards, with the mucus escape reaction, the fluid is contained by the granulation tissue, and with the salivary duct cyst, the fluid is contained within epithelium.
Epithelial line.
Yes.
Sac, yes.
Okay, thank you.
Yes, very good way.
Because I would take it up on Monday.
Start to look
This is what I was talking about because this is where I was confused because I remember I asked you. I said if I study from here, you said everything you study that would show up would be here, and notes were for personally for us. I do take notes. They're on my laptop.
I think you misunderstood what I said. I didn't say that you wouldn't be tested on anything except what's already printed.
Oh no, I asked you if I
Most
studied
of
this.
what? Most of what you need to know is already printed, but not everything. Not 100%. So that's, yeah, you need to be careful.
And this is where I was reading it. It said where that oral cancer is about 5 times higher. What is it? Smokers also have high risk of developing. Cigarette smoking is the main cause of cancer mortality in the U.S. So that's why I thought it was.
Yeah, but that isn't comparing it to, this is just cigarette smoking data related to oral cancer, but this is not compared to other forms of tobacco use. This is just what the data is for cigarette smoking
Main cause. That's
for,
why.
for oral cancer, but that this is not an analysis of the different forms of smoking compared to each other, or the different forms of tobacco use compared to each other.
So on the test for
So,
again.
so I asked a question that has information that comes from different places in your handout, not just all one place.
So on the test, you want us to put, if you were to bring it up, the reversible smoking.
Not reversible
Or
smoking,
the-
reverse smoking. Did we talk about reverse smoking?
Yes.
Yeah.
India. I remember that. I just didn't see here. That's why I thought I learned this one.
I'm glad you learned that one, because tobacco smoking is the leading risk factor for oral cancer, but the way you use your tobacco and the way you smoke it does make a difference, and that's why we talked about the importance of
I remember that
taking
one.
the
Yeah.
history.
Recent
Yeah.
one was worse.
Yeah,
and
and you
this
should have
caused-
written it down. You should have written.
I remember it. It's just that, because it said the U.S. and that's in India. I was like, okay, we're in U.S. That's why I remember this
But
one.
we have lots of immigrants from India.
True.
So we have to be aware of other cultural issues because they could be a factor for our patients.
All right, thank you.
Good questions.
I need some light. During the break, I gotta wake up a little bit.
The mucus escape reaction and the salivary duct cyst, the only way to differentiate them is pretty much the location, right? Because they're going to look the same, right?
They're going to look a lot the same. They're going to have a little bit different history in terms
Yes.
of onset, but location is very, very helpful. What's the most definitive way to tell them apart?
Well, it's just,
The histology,
Well-
the biopsy.
yes.
But prior to the biopsy, we go with location and odds.
yeah, pretty much.
The more common disease is the more likely answer, but if it's not in an area that's easily bitten, I would favor our salivary.
Now,
So location is very helpful.
Could you explain again what was that make a cyst? Like,
What makes a cyst a cyst?
yeah, like what was the difference? Like what does a lesion have to have for us to call it a cyst?
It has to be a cavity or sac filled with fluid, so it's supposed to contain fluid, and it has to be lined by epithelium for it to lead to cyst.
So
Now, we have a lecture next week on cysts that are in the jaws, and so that'll be more clear when we talk about it. But you've also had soft tissue cysts.
yes.
So what soft tissue cysts did we talk about?
I mean, that was what I was a little confused, but maybe
So they all were a collection of fluid
Yes.
surrounded by an epithelial lining. They're soft tissue cysts.
so. The
Like fibroglossal duct cyst or branchial cleft cyst or nasolabial cyst.
So-
Fluid.
the first part that we covered, the first one that was not assessed, right?
The mucus escape reaction is not a cyst. It's a collection of fluid, but it has no epithelium around it. It just has granulation tissue, which is all connective tissue, no epithelium. So you know what granulation tissue is. It's
Okay.
repair tissue, fibroblasts and blood vessels, no epithelium.
Okay. Thank you. So it's pretty much. So can we always expect the cyst to be thicker, and in a way, no?
You can't really tell.
Okay, so they have
Sometimes
to
the
go.
epithelial lining is very thin. It can be very
Pretty much
thin.
They have
So you
for us
really
to
have
have a
to have
definitive diagnosis. We have to send them to biopsy, right?
Yeah, definitive diagnosis, absolutely.
Okay. Thank you, Doc.
So that's what she wants to know, like, what was going on Thursday. So that's why I was like, so that's why I want to talk to last month. I already contacted I got from the kid.
This one is not detecting more than this one. I'm getting very
Do you want
noisy.
to plug it or something?
It's like relay the message.
My other computer detects that there's another display.
But yeah, so I'm going to do her again to see what's happening. Yeah, we don't use it. I know it won't, so this is why. Yeah, but it's still it's easy point. Yeah, that's true. So I talked to her, I sent her like a concern email.
Okay.
My grade.
The question I have here, rating questions are just like the ones you've asked.
The clinical questions are very
She's
similar.
like, well,
The written.
The written ones are similar as well.
Okay, and then,
Except they're all multiple choice. That's it. They're multiple choice.
it would be unexemplified.
so if you guys are willing to do it together.
I have an hour and a half. An hour and a half, and
But it's unexemplified.
it will be on the And I'll make an announcement at the end of class.
If I wanted to go over this last
Yeah,
week,
exactly. Especially for like easy points.
you'd be available later today or next week? Or I guess maybe a little bit after class. It's okay.
I haven't even started writing the exam.
Oh, okay. Oh, okay.
And as it is, I'm going to have no weekend, so I was planning to cloister myself this afternoon.
Okay.
I had planned to go home to work on it, but I don't know what's happening. So my son plays house for me and his girlfriend. They usually play house on Thursday, but they decided they were going to wait till today. If they're cleaning house this afternoon, I cannot get here. So I might be here. If I'm here, I don't mind meeting with you. So send me an email. You could come up right after class. That would be fine. Yeah,
Just like
maybe
one or two
we should do that. Yeah, maybe we should do that.
If you don't mind.
Yeah, I don't mind. It's just that I.
Yeah, I don't think she's gonna do something.
Okay, thank you so much.
All right. Very good. Why is it not detecting another display?
Yeah, sure.
For this one? Where's AJ? Are you busy?
I'm just frustrated.
I wish I could help
Ask your
you.
question.
Okay.
Oh, my other computers recognize in here that there's more than one display.
Oh, because you're getting a new computer.
Yeah, this is the first time I've bought a new laptop. I have to give back my loaner, so.
Okay. So you're gonna get your other computer.
You're right, you're typing the wrong stuff. So I'm listening.
Oh, okay. I put March next.
That's a good answer, but you should probably take it a little farther because the most common thing that causes enlarged lymph nodes is when we're fighting an infection.
Right.
And you should be able to tell a reactive lymph node part of the one that's suspicious for malignancy.
Okay.
But no, I'm actually very happy with that. That's good enough.
Okay, and then for the for the detailed ones, for the fixed tooth, I put fixed tooth, but I didn't put come back 10 to 14 days. I thought I knew that. Is that okay?
I haven't decided what I'm going to group.
Okay.
Sometimes those questions that are super open-ended, I look at all the answers before I finalize my rubric and then decide how I'm going to apply it.
Okay.
I kind of look at the spectrum of answers to decide what's a reasonable thing to expect.
Okay. That makes sense. Okay. So it's just
Because sometimes that way the story is more fair.
that makes sense. Thank you.
I'll decide when I get to it.
Do you, like, what did he?
This is just not detecting that I'm connected to something else, and I can disconnect it, and I can connect it, but it's just duplicating on the other monitor. It's not detecting that it's a separate line.
Oh, yeah, I don't know. I know that AJ.
And I do not like this.
Sorry.
We need to get going. Quick question. Except for it to be there. This is how you find it. So the question was, how do you know that there's even an it present? So what are you looking for that even says there's an it present? That was what the question was about. Because we can't usually see it. There's not usually a math photography. It's usually and that's what we talked about in class. So this is relevant for oral cancer, but oral cancer is really a different beast. Maybe so, but maybe you didn't write it down. It's something you talk about in class. I can't guarantee that there are no questions on the exam that are not from things you should have written down or not. Most of it is in not a lot, but in terms, but the handout I most likely get asked numbers and percentages is
Oh, you were the one.
like the track. I just don't think. All right, ladies and gentlemen, I think our break time is over. And we need to get back to business, or I'll have you here till noon, and I don't think you want to be here till noon, and I know I don't want to be here till noon.
What time? Are we done at 11?
We're supposed to be done at 11, but we're not making very good progress to that end.
Hurry up! Hurry up! He's like,
Oops, which one? My battery finally totally died. There we go. Yes, it's green. And there was light. All right, so we have our mic so we can go on. We are still on our non-neoplastic disorders of salivary glands, and the next thing on the list I should have talked about before the break, and that's the ranula. Ranula is a clinical term just like mucocele. Technically, it refers to a mucocele in a specific location. It is a pool of salivary mucus that collects in the floor of the mouth region. The overwhelming majority of the time that we get these, they are large. They're due to rupture of Wharton's duct, that submandibular duct. And that large classic ranula is virtually always a mucus escape reaction. And so if you use ranula as a diagnostic term for a mucus escape reaction in the floor of the mouth, you actually get away with that. The only time you wouldn't get away with that is if it's not that large classic ranula. So the word ranula actually refers to frog belly. It means frog belly. You know how frogs, they expand their throat to attract mates? It kind of looks like that expanded throat. Why they call it frog belly instead of frog throat, I have no idea, but it refers to the ribbit. It refers to the frog appearance. So these are Swellings in the floor of the mouth that have a lot of saliva in them, because when Wharton's duct ruptures, and don't ask me how you do it. Kids manage to do it more than adults, but if you rupture Wharton's duct, it comes from a gland that produces a large volume of saliva, so we get a large swelling in the floor of the mouth. These are often more in the anterior area because that's a place where it's easier to have some trauma that can reach Wharton's duct and cause it to rupture, but these can be really very large swellings. And they are going to have a history of recent and rapid onset. They typically have history of swelling up more at mealtime and shrinking down a little bit in between meals, and they tend to be painful. So they swell up fast enough that it stretches out the tissue, and that produces a pain response. So this is a pretty classic great big one. Come on, there's a nice classic great big one. This one, a little tiny one. That one probably still is a mucus escape reaction, but not from ruptured Wharton's duct. That would be a minor duct that got ruptured in the floor of the mouth. But clinically, you could still call it a ranula. Question?
So the difference between a ranula and a dermoid cyst would be its fluctuation?
There are lots of differences between a ranula and a dermoid cyst. Number one, dermoid cysts are very uncommon. They are a cavity lined by epithelium, but they don't have regular fluid in them. They have mostly shed keratin from the lining, the epithelial lining. And because of that, they're not very fluctuant. They tend to be more doughy. They're very, very, very uncommon, and they're very opaque and tend to be very deep. So they're going to have a very different presentation. Even though they're in a similar location, they're going to be deeper. They tend to produce more swelling that's visible from extraoral and not have this superficial swelling that increases at mealtime and lifts the tongue up. If you shine a light on these are translucent. You would never see translucence in a dermoid cyst. So clinically, you should not have difficulty distinguishing those. Treatment for ranula is excision of the mucus escape reaction part and repair of Wharton's duct. Do you think that's an easy thing to do? You are correct. It is not an easy thing to do, and should be attempted only by an experienced surgeon. And patients who have ranulas and their parents, because these are often children, need to be told ahead of time that it may require multiple surgeries before the problem is completely corrected, because it's just a very difficult thing to accomplish. And with the first repair, there can be continued leakage. And so recurrence of ranulas is very, very common, and further surgical treatment is often necessary. I've heard of patients that had like 4 or 5 surgeries before they finally got rid of them. And it's very helpful for them to know up front that this is typical. You tell them after the fact and they think you're just covering for the surgeon. It was a bad surgeon. But that's not the case. It's really the nature of the disease process. So that's the ranula. Good prognosis, but it can take a while to completely eliminate it and may require multiple surgeries. We move on to something else, very common, and that is sialolithiasis. A lith is a stone. So sialolithiasis is the name of the disease that we get when we have stone formation within the salivary system. When we have stones that form elsewhere, like in the kidneys or in the gallbladder, gallstones and kidney stones, they usually form because of supersaturation of excretions, and then we get precipitation of salts. But salivary stones form a little bit differently. They usually occur not because of supersaturation of the saliva, but because there's some protein that's present that kind of settles out and then gradually starts collecting calcium as it goes by. Saliva has a lot of calcium. It's supposed to. It helps remineralize our teeth, keep our teeth healthy, and so stone formation happens pretty easily. The most common place to get salivary stones is in that submandibular duct. And the reason for that is twofold. The duct runs parallel to the surface of the earth. It doesn't run on downhill course and drain nicely. It runs parallel. Furthermore, it's not perfectly flat. It has an undulating kind of course. And so in those little valleys, if you have increased protein content in the saliva, it's easy for protein to settle out. So what makes protein settle out in the valleys? When you don't have good flow. So it's really related to lack of good flow. So patients who have dry mouth that don't drink enough water, if you have an infection and get some exudate, the protein in the exudate might settle out. But dry mouth and not drinking enough water are very common things that tend to promote stone formation. When we remove the stones and cut them in half, we very frequently find a soft center that still persists in the middle. And then the outside is like layers, like a jawbreaker. Very, very common. There's another one, a little more round, but they're not always truly uniform. We can get them even in minor gland ducts and in the parotid duct, but they are most common in submandibular duct. Patients don't usually know that they're getting a stone until it gets big enough to produce obstruction. So as long as there is room for saliva to sneak around the stone, they don't know they have it. And occasionally these can get quite large before they produce enough obstruction to bring attention to their presence. When they cause obstruction and prevent outflow of saliva, the saliva backs up into the gland and that produces pain and swelling in the neck area, submandibular area. So sudden onset of pain and swelling, but way back, not under the tongue where the stone would be, but way back in the gland area is typical for sialolithiasis. So here's a patient. Presents with recent onset of pain. Pain is worse at mealtime, but when you look at the swelling is in the neck area because the saliva backs up all the way into the submandibular gland. So does that make sense? Yeah. And there's another patient. I happen to know who he is because he was a dental student when I was a student. So he got a stone as a dental student. I can't tell you who it is.
Isn't that the guy that taught to us?
Nope.
Oh.
Nope. He took the picture. Dr. Thompson took the picture. You can probably figure out who this is. I think he was class of 81 or 82. Go look at the pictures in the hallway. You'll find him. Sometimes we know it's a stone from the history and can go looking for it to confirm our diagnosis. If the stone is in a very anterior location, we can actually see it in the duct and see it got far enough, it got to the end and it couldn't get through. And you can palpate it and it's hard as a rock. It makes the diagnosis very obvious. But a lot of times it doesn't get that far and we can't see it. Have you palpated the floor of the mouth and palpated Wharton's duct? It's really thick. It's kind of a firm tube, and so it can be difficult to feel a stone inside of it. So we like to take radiographs. An occlusal film, even if you're looking further back, you can often get an occlusal film that will show the opaque stone in the soft tissue zone. And that kind of confirms your diagnosis too. Then you send the patient to the oral surgeon to have it removed. We do not recommend that sialoliths be removed by general dentists. Because if you don't know what you're doing, you're going to cause a ranula. It makes lots of sense. Now that we've seen a ranula, we don't want to cause one. Those are big enough trouble all by themselves. Some conservative therapies have been tried and are occasionally recommended to patients. Drink lots of water and suck on lemon drops to produce a surge of saliva to expel the stone. Well, if the stone is already causing obstruction and that's how they found out they had it, what is more saliva production going to do? Increase the swelling and the pain. So I kind of think it's a cruel recommendation, and I don't advise it. If the stone hasn't gotten out on its own already and the patient's having pain and swelling, increasing saliva production is not likely to expel the stone. So it is usually best to send the patient for immediate referral to the oral surgeon. And the surgeon sometimes can dilate the duct. They can use a cannula to stretch the duct out to make room for the stone to pass. or they can surgically remove the stone and repair the duct. Any questions about sialolithiasis? That's usually one that's pretty easy to recognize. We move on to dry mouth. I don't want to say a lot about dry mouth, but I do want to say that dry mouth is not just about patient perceptions, because patient perceptions are not always correct. If the patient says my mouth is dry, it should be evaluated, but sometimes their mouth is not as dry as they think, and sometimes they have a different problem. And if they really do have dry mouth, we can often see changes that objectively support their claim that my mouth feels dry. Things that we see is lack of pooling of saliva in the floor of the mouth, lower vestibules, but we also see loss of taste buds over time. We call that atrophic glossitis or papillary atrophy of the tongue, but it's very, very common to get a bald tongue when you have chronic dry mouth. What else can have a bald tongue besides just ordinary dry mouth?
No, it's candidiasis.
Candidiasis. Chronic atrophic candidiasis, erythematous candidiasis, can have a very bald tongue. And sometimes we have both at the same time, because dry mouth also promotes overgrowth of yeast, and so candidiasis is very common in patients who have dry mouth. But we can usually see changes that support their claim. What causes dry mouth? By far and away the most common cause is medication, side effect of medication, blocking appropriate stimulation to the glands. And so that's always the thing that we look for first. And many patients are taking multiple medications. Dr. Heidi Christensen, who has worked with oral diagnosis for many years here at the School of Dentistry, was walking down the aisle in the clinic one day, and this was a patient who presented for comp oral eval. We tell them, bring your medications. He brought his medications. Wow. There's a word that we use when patients take that many medications. Do you know what it is? Polypharmia. Yeah, you heard that? Don't you think that the likelihood of dry mouth, medication-induced dry mouth, increases the more medications you take? Yes. Yeah. So a lot of patients actually are taking multiple xerostomach medications, and that compounds the effects on the glands. And the amount of dry mouth can be very significant for those patients. Other things that contribute to dry mouth include smoking, mouth breathing. It's not a reduction in saliva, just not enough saliva to prevent the mouth from drying out when they're breathing through their mouth. Don't you like him? He's our mouth breather. And just aging. So, at what age do we have the most saliva? 21. Anybody who's ever worked with young babies knows that babies have tons of saliva. And maybe it's just because they haven't learned to swallow it yet, but babies are drool and poop factories. That is their major purpose to exist, I think, in the first year of life. Eat, sleep, poop, drool. That's what it's all about. But as we age, we do have some decrease in salivation, so that's a cause as well. There are other important causes of dry mouth that we have to think about in our profession. They are things that destroy the salivary glands, where we would have permanent loss of ability to produce saliva. Important ones include irradiation. So if we have head and neck irradiation to treat cancer, the salivary glands take a heavy hit. So that destroys acini, and they don't all regenerate. So we usually have some permanent loss of salivation. Why would you have head and neck irradiation? To treat oral cancer, oropharyngeal cancer. That's actually the most common treatment for oropharyngeal carcinoma is radiation. They just radiate the whole band all the way around because they can't usually find the stupid things. So, interesting. And for intraoral carcinoma, and sometimes we get scatter radiation when they irradiate the neck if the patient has thyroid cancer that can't be completely controlled with surgery. So local irradiation happens. The newer techniques are kinder to the tissues, but the salivary glands still really take a big hit. Question?
So the line that goes across right there, is there like a plate or something?
Can we come back to the picture in just a second? Okay. So the other thing that we have to think about are autoimmune diseases. There are autoimmune diseases that destroy the salivary glands. Sjogren's syndrome is the most important one to talk about. We will talk about that one briefly. But there are some other autoimmune diseases that can also attack the salivary glands, destroy the acini, and cause permanent reduction in salivary flow. These two pictures are taken from a patient who had radiation therapy for oral cancer. And this is actually an upside down picture. These are the mandibular teeth. It's a mirror shot. If I cut it off here, you wouldn't have known it was a mirror shot. But I think it's easier to see it with the teeth down because that's the way we're used to looking at patients. So I flipped it over and you're looking at the mirror shot. So there's a plate. It's a mirror. Yep. And the teeth are up there. Do you see how dry and kind of wrinkled the tissue looks? Yeah. It looks dry. We have some papillary atrophy. We see a lot of plaque in the patient. And this view, you can see how dry it is. It's wrinkling. You can just see it's bone dry in this patient. No lubrication. No lubrication at all. But that was a patient who had irradiation. If the parotid and submandibular glands are in the field of radiation, we get the most dry mouth. If we just get some radiation damage to the minor glands, that works out a lot better for the patient. There are lots of consequences of dry mouth. It does allow overgrowth of harmful bacteria that causes both decay and gum disease, as well as specific infectious organisms like Candida. So candidiasis is common, as well as greater periodontal disease and caries. It causes the atrophic glossitis that we already talked about. It also causes generalized atrophy of the mucosa, so the epithelium becomes thinner and more easily traumatized. Patients with dry mouth have frequent trauma to the tissues from very ordinary types of things because there's more friction and the tissue is thinner. So that's kind of a problem. Tissue can become very thin. And of course, if you don't have any lubrication, it can be difficult to eat and swallow and speak. So I think management of our dry mouth patients is very, very important. If you talk to a dentist about management of the dry mouth patient, what do they think about first? Every time. Protecting the teeth. Fluoride. Oh, we got to give lots of fluoride to this patient. But they forget to think about the other things. One of the most important things in the management of our dry mouth patients is liberal use of lubricants. Patients need lubricants. We used to call them artificial saliva, but that kind of grosses out patients. It kind of sounds like putting somebody else's saliva in your mouth, which is kind of disgusting. So we call them oral lubricants. Oral lubricants in recent years have become widely available. There are lots of brands. Almost all drugstores have more than one brand to try. And sometimes patient A likes this one better and patient B likes that one better. So my patients with dry mouth, I start them off with samples. The company that gives the free samples is Biotene. That's a good one to start with. But I tell them, go to the drugstore, try lots of different brands, use the one that you like. What's the number one comment I get back from patients when I see them for follow-up? Well, it doesn't last very long. Well, why would you expect it to? That's why you have to use them liberally. It's not a cure, but you do have to use frequent lubricants. The Biotene products, they have the mouthwash, which is moisturizing, but you can't swallow it. The spray is better. We get samples of the gel. Have you seen the gel, Oral Balance gel? Very few of my patients like that gel. Very, very few. I don't know why. The one place I find it to be helpful is in a denture in a dry mouth patient. It makes a really nice cushioning, moisturizing layer before you put your dentures in. But other than that, most patients like the rinses and the sprays the best. My favorite one is mouth coat spray, and it's cheaper than Biotene too, but you can only buy it online. You're not going to find it in a store. Chlorhexidine can be helpful to reduce harmful microbes. Xylitol gum helps promote salivation and is a sugar that doesn't promote growth of cariogenic bacteria. Sometimes we can use sialogogues, which are drugs that increase saliva output. But if you've destroyed your glands, they don't really work very well. One of the side effects of the sialogogues is they also cause sweating. And patients really don't like that. So a lot of patients will fill the prescription and never refill it and not use it twice. Physicians tend to prescribe them and say, take this once a day in the morning or twice a day, just randomly. If a patient is going to use a sialogogue, the best time to take it is half an hour before meals. So you get your surge of saliva production and the associated sweating when you're eating, and then it kind of dissipates in between meals, and patients do pretty good with that. So that's all I want to say about xerostomia in general. We move on to Sjogren's syndrome. Sjogren's syndrome is the most common autoimmune disease that destroys the salivary glands. It was first recognized in association with rheumatoid arthritis, and we now recognize that as secondary Sjogren's syndrome. Primary Sjogren's syndrome is when the autoimmune disease is only in the salivary and lacrimal glands, producing dry mouth and dry eyes. But more patients have Sjogren's syndrome and associated with some other autoimmune disease than having it as primary. So most patients actually have secondary disease. But we get inflammatory destruction of the salivary acini, so eventually we just pretty much have ductal structures left. And eventually the salivary glands end up looking a lot more like a lymph node. A biopsy is helpful for diagnosis. I don't know that you need to know about the diagnostic criteria, and they're working on other ways, non-surgical ways, to confirm a diagnosis that are a little easier on patients. The easiest way to sample glands is actually to sample the lip minor glands. They do show the same changes that we see in parotid. Doing a parotid biopsy is very hard, so we don't want to do that. So primary Sjogren's syndrome, when it's just in the glands, will present clinically with dry eyes and dry mouth, but we can do blood tests to look for autoantibodies that are indicative of Sjogren's syndrome. Patients should have either anti-SSA or anti-SSB elevated. SS does stand for Sjogren's syndrome, but they are actually antibodies to ribonuclear proteins. You know what RNA is? So they're autoantibodies that are attacking RNA, but they're associated with Sjogren's syndrome, so they have these names. But sometimes rheumatoid factor is also elevated, and antibodies to other nuclear proteins, DNA-type proteins, so they can have an elevated ANA as well. In secondary, dry eyes, dry mouth, but some other recognized autoimmune disease, most commonly rheumatoid arthritis, but it could be systemic lupus erythematosus or any of the other autoimmune diseases. So, can you see that her mouth is dry?
Yeah, her tongue is like.
Her tongue is a little atrophic, and it reflects light differently than a mouth that has lots of saliva. Do you see that she's had a lot of decay? In an older person, and usually Sjogren's syndrome presents in middle-aged and older individuals, they often have a little periodontal disease, so they have some exposed roots. That decays first because it's softer. So cervical decay and all these cervical restorations is a typical finding in patients who have chronic dry mouth, but we see it elsewhere. Do you believe that she has dry eyes? Can you see the irritation in her eyes? How they're red? So red irritated eyes are very, very common. Sometimes we don't see any red irritation, but the patient will tell us, I have to use eye drops all the time. I'm using eye drops a lot for my eyes to be comfortable. This patient, I want to say one more thing about this one. Sjogren's syndrome is much, much, much more common in women, as are most autoimmune diseases. But I do have a male who had it, so sometimes it is in men. What I like about my male patient with Sjogren's syndrome is you see the little parotid swelling. He has some diffuse enlargement of the parotid glands. That sometimes is present early in the course of disease, not always, but he shows it very nicely, so he makes a good patient to demonstrate that feature. What do you think of his eyes? They look pretty good. So you would have to get the history from him that his eyes are irritated frequently and he uses lots of eye drops. Do I have to tell you that his mouth is dry? Do you see the evidence of the dry mouth? Yes. New cervical caries, old cervical caries. Yeah. So we have lots of evidence and you put it all together and it fits nicely with Sjogren's syndrome.
I have a question.
Yes.
How do you know he has a dry mouth? I don't see the wrinkle.
These you don't see the wrinkles, but you see the decay evidence. And it's in that telltale place in the cervical area, the exposed roots. So he shows the consequences of the dry mouth. So you should have a suspicion of this. Cervical caries is something that we typically see in dry mouth patients and not so much due to the other routine causes of decay as much.
The difference between the primary and the secondary, is it important to focus on those?
Yes,
Okay.
because you always want to know if is this primary or secondary Sjogren's syndrome. So if there's no evidence of some other autoimmune disease, it's primary, and if there is, then it's secondary Sjogren's syndrome. So you should know the difference. Patients with Sjogren's syndrome are treated by dentists and rheumatologists and ophthalmologists and are generally treated symptomatically. We do not have good drugs that control it and prevent its progression like we do for other autoimmune diseases, but they're working on it. We're just not there yet. And so they are largely treated symptomatically, and they need lots and lots and lots of xerostomia management to keep their mouths comfortable and healthy, and so that's a good thing. One last thing I want to say about them. The autoimmune disease that's destroying the glands has an increased risk of undergoing malignant transformation into lymphoma. All of those lymphocytes that aggregate and destroy the glands can become cancer. So that's something that patients have to be monitored for. This was a patient that we saw in our own clinic here at the School of Dentistry who had enlarged submandibular glands that had developed over about a 2-year period, and then he started getting swelling in the palate. And he had dry mouth. We were worried about Sjogren's syndrome, sent him to the rheumatologist. They did biopsy, and it was lymphoma. He already had lymphoma. So that's definitely something that has to be monitored for. All right, we do not have a lot of time, so we are going to do the quick and dirty discussion on salivary gland tumors. We're going to do it in 20 minutes. Get out at 11. Salivary gland tumors can be benign or malignant. Which is more common? Benign are much more common than malignant. And depending on the site in the mouth, there's about a 50-50 chance of some locations the salivary gland tumor being malignant, but at most locations the benign tumors are much more common. The single most common salivary gland tumor is a benign one. It's our pleomorphic adenoma. If you don't learn anything else about salivary gland tumors, you have to know about pleomorphic adenoma. So make sure that you study that one very, very well. Most of our salivary gland tumors can occur at any salivary gland location, but not all of them. So one of the things as you go through and do your private study, you do want to pay attention to the ones that occur generally in a specific place, okay? Because you would only consider it on the differential diagnosis if you have a mass in that location. So that makes sense. There are more malignant ones than there are benign ones, unfortunately. Mostly you need to recognize their names, and the one that you'd have to know the most about for the malignant ones is our mucoepidermoid carcinoma, because it's the most common salivary gland cancer, okay? So we're going to emphasize pleomorphic adenoma and mucoepidermoid carcinoma, and just know a little bit about the other ones. Another name for pleomorphic adenoma is benign mixed tumor. How do we usually use the term pleomorphism or pleomorphic? Is that a word you learned with Dr. Grandi? Yes. It was a word that we used in the context of malignancies and dysplasia to refer to variation in appearance, size, and shape and appearance of one cell compared to the next. So it usually applies to cancers, but this is a benign tumor. So we don't like that the World Health Organization wants to call this pleomorphic adenoma because this is not a cancer. It is a benign tumor, but it has more than one cell pattern, more than one morphologic cell type in it, and that's actually what the pleomorphic refers to, more than one morphologic cell type. But it's all benign. It is by far and away the most common salivary gland tumor. It accounts for half of all salivary gland tumors in major and minor glands and 90% of all benign tumors. So it's really common. Where does it live? Anywhere we have salivary glands. We see it frequently in the parotid gland and the minor glands. So I brought some pictures. This is what it looks like histologically, and it has some kind of ductal structures, and it has some fat that gets in it, and then it has areas that looks like cartilage, but that's actually from epimyoepithelial cells. It just looks like cartilage. And then some areas where it's really cellular, they say it looks like a swarm of bees. See, there's our swarm of bees, there's our cartilage, here's our ductal part. So there's a variety of appearances of the cell types, and that's what the pleomorphic part refers to. Would you recognize that this is a parotid tumor? Do you see a mass there? Yes. You notice that it's fairly round. When we see fairly round and uniform things, that usually goes with benign. And when we palpate this, it's movable, and that fits with benign. So these, when they occur in the parotid gland, usually present as a slowly enlarging, round, sometimes a little lumpy, but fairly round, well-defined, movable mass. They are firmer than normal tissue, but they're not hard. They're just firm. So whenever we see that clinical pattern of mass in the parotid area, and that is the parotid area, the most likely diagnosis is benign mixed tumor, pleomorphic adenoma, just because that's the most common one. By far and away the most common one. So does that make sense? Sure. Sometimes they're small enough we don't see them very easily, but we can palpate them. You can palpate them anterior to the ear in the main body of the parotid area. But don't forget about the tail of the parotid. Did you learn about the tail of parotid in anatomy gland? Parotid gland can have a little tail on it that kind of sneaks down below the angle, and we can get tumors in that area. And this one's the little tail of the parotid mass right there. And if it's in that tail of the parotid, still the most likely diagnosis is pleomorphic adenoma. They can occur in the minor glands of the palate. When we have benign neoplasms that occur in the submucosal area of the palate, it is far more likely to be salivary origin than other connective tissues. Even though there are nerves and blood vessels that live there, they don't have tumors very often. When we get salivary gland tumors, they tend to be located about halfway between midline and the gingival crest. So the middle of them is about halfway in between, from about here down to even into soft palate. So there it is, fairly round, palpable, firm mass. If it's in the hard palate, would you expect it to be movable to palpation? No, because the tissue isn't very movable that hosts it. So you can't test for that, but tend to enlarge slowly. This one's one of my favorite cases. The dentist did not see this tumor until he prepped the teeth and took the impression and then poured it up and saw it on the SETI model. And that just cracks me up. So dentists look at teeth. That's why they need their hygienist to look at everything else, because you're really good at looking at soft tissue, and they're always looking at teeth. I can't believe they didn't see that. Cracks me up. Yeah, so once the dentist did see it, did send the patient to the surgeon, and this was a pleomorphic adenoma. Nice benign tumor is removed by excision. We do remove them with a border of normal tissue because they have capsule problems. The capsule doesn't always contain the tumor adequately, so if you just peel them out by the capsule, they usually recur. So we have to remove them with a border of normal tissue, and we do need to follow them for possible recurrence because they are just kind of famous for recurring. What happens if you just leave them there? it's a benign tumor. Why don't we just leave it there? They grow slowly. They're not going to cause any trouble. Not entirely true. If you leave them there long enough, they can undergo malignant transformation. So it is important to remove them so they don't have that opportunity. If we do have malignant transformation of a pleomorphic adenoma, the name that we give it is carcinoma X pleomorphic adenoma, means carcinoma arising in a pre-existing pleomorphic adenoma. And things that we see in association with malignant transformation into carcinoma X mixed tumor is a tumor that's been there for many years without excision, usually at least 10, or has had multiple recurrences and re-excisions. So it's better to do a little bit better initial excision and not have recurrences. Recurrences are associated with greater risk of malignant transformation. The majority of these are in the parotid gland, where it's a little harder to get them all out. So they've gotten to the place where trying to get a border of normal tissue, forget it, just take the whole lobe of the parotid out, and then we have better results and fewer recurrences and less risk for malignant transformation. So, does that look like it might be malignant? Yeah. So what are the red lines on him? That's where they're going to cut to remove this. So this was a recurrent pleomorphic adenoma that underwent malignant transformation. It's very, very firm, it's fixed, and it's got the erythema of the overlying skin, which is a sign of malignancy, and now is going to require much more radical surgery. And might already be metastatic, could kill the patient, yes.
So they would also remove the bone?
If it's invading into bone, they may have to remove bone, but they will remove the soft tissue. They remove, in a radical neck dissection, usually the sternocleidomastoid muscle, the internal jugular vein. They remove a lot of tissue. They are doing a little bit more modified radical necks now that are a little more conservative and less debilitating to patients. But they have to take a lot of tissue to get an adequate margin. So we don't like to give these the opportunity to undergo malignant transformation. Warthin tumor is much less common than pleomorphic adenoma, but it's an interesting tumor that occurs in parotid gland. Doesn't occur in other places except very rarely in submandibular gland. So this is one you should associate with parotid gland. And it actually is a tumor that has salivary gland benign tumor mixed with lymphoid tissue. So it looks like it arises in a lymph node, that it's a salivary gland that arises from salivary tissue that was entrapped developmentally within a lymph node in the parotid gland. So it's very interesting. When we look at them histologically, they have lymph node tissue. And they have these little cavities that are formed by the neoplastic benign salivary gland epithelium. It has another name. The proper World Health Organization approved Latin term is papillary cystadenoma lymphomatosa, which is an awful lot to remember. So if you want to call them Warthin tumor, you are welcome to do so, and everybody will know what you're talking about. It's much, much easier to remember than papillary cystadenoma lymphomatosa. But there's one. How can you tell Warthin tumor apart from pleomorphic adenoma clinically? You can't. What's the most likely diagnosis? The more common disease, which is pleomorphic adenoma. So the only way you would know you're working with a Warthin tumor is actually to have histology and know that it has lymphoid tissue in it. But it has an excellent prognosis, and it doesn't recur because it has the capsule of the lymph node outside that helps contain it, which is very nice. There is one other benign tumor I want you to know about, and that is canalicular adenoma. This one used to be called monomorphic adenoma, but because it has one morphologic cell type, but there were actually two different ones that were monomorphic, so we gave them individual names. The most common one is the canalicular adenoma. It is way less common than either pleomorphic adenoma or the Warthin tumor, but it does have a unique presentation, so we usually have a clue when we're working with it. It is almost always a slowly enlarging, localized, movable mass in the upper lip of an older adult. the upper lip doesn't get tumors and doesn't get reactive lesions very often. We don't get much at all that happens with the upper lip. So when we have a mass in the upper lip of an older adult, it is considered to be canalicular adenoma unless proven otherwise by biopsy. That is the number one thing that we see in the upper lip. And there it is, a movable submucosal mass in the upper lip of an older person. Perfect for canalicular adenoma, but you're not going to see very many of these. Might make a really good written question on a test, more than a clinical question on a test. So we have 5 minutes to talk about malignancies. I might have to finish this one next week. Signs of malignancy for salivary gland cancers. Irregular outline instead of being round or oval and uniform. Firm and fixed instead of firm and movable. Induration, firm and fixed to underlying surrounding tissues. Surface ulceration. Surface ulceration is very suspicious for malignancy. A persistent ulcer, an ulcer that doesn't have any reason to be there, no history of trauma, not healing, particularly overlying a mass, is a sign of malignancy. And really prominent blood vessels or vascularity. And that's because cancers produce vascular endothelial growth factor, which promotes angiogenesis. They grow blood vessels to bring them blood so they can grow in size. They exist to support their own existence. And that's about it. So that pronounced blood supply is an important sign of malignancy as well. And obviously destruction of normal tissues. So by looking at a tumor, we should be able to see some signs of malignancy. If we see signs of malignancy in an area where salivary gland tumors are common, then our differential diagnosis should be built with things that are cancers, salivary gland cancers. If there are no signs of malignancy, then we build our differential with things that are benign. That makes sense? All right. Mucoepidermoid carcinoma is the most common salivary gland cancer. Is the most common salivary gland cancer in the parotid gland, the minor glands, the sublingual glands. The only place that has a different salivary gland cancer most commonly is submandibular gland. We still get this one there, but it's just not the most common one. But it's still the most common overall. It tends to occur in young adults more than older adults, which is a little bit unusual for cancers. Most patients who get cancer are over 40. This is more common in the 20 to 40 range, which is a little bit unusual about it. It gets its name, mucoepidermoid carcinoma, because it has two cell profiles. Part of it looks like mucus-producing cells. Those are the pale ones. That's the muco part. And part of it looks like squamous cells, which is the epidermoid part. So an old name for squamous cell carcinoma was epidermoid carcinoma. So mucoepidermoid carcinoma means we have a cancer that looks like part squamous cell carcinoma and part mucus cell carcinoma. Does that make sense? Sure. Sometimes the mucus cells are few and far between, and we have to do special stains to see them. The more mucus cells we have, usually the better they behave, the less, the more aggressive they are. So, do you see the tumor in this patient? Is this patient 20 to 40 years of age?
No.
No, she's over 40, but she broke the rule. Anybody see the tumor?
On the lower left, patient's lower left.
Patient's lower left.
Jawline.
Oh, so you were looking, my arrow didn't stop too soon. You're looking at this? Those are just jowls from your face sagging as we age.
Okay.
She needs a facelift. It's actually this little lump right there. There was a little tiny lump, and at further examination, she had this intraorally. That's on the crest of the edentulous ridge. She's older and edentulous. And what do you see? Persistent ulceration. This was indurated, and what's next to it? Some white, looks like leukoplakia. So if you saw this in your patient, what would your number one diagnosis be? Oral squamous cell carcinoma. But when it was biopsied, it was found to be mucoepidermoid carcinoma, and everybody was very surprised. Very, very surprised. This is one that's arising in the minor glands in the palate, right here. A red, it looks fairly small, but it's very, very red, so that's a sign of malignancy. You wouldn't probably have much suspicion on that one. That's not a good one for testing, but it was a mucoepidermoid carcinoma. And this is one that's arising in the minor gland in the cheek and surrounding the parotid papilla. So it can present lots of different ways. But if you see a mass in an area where there are salivary glands and it shows signs of malignancy, your number one choice should be mucoepidermoid carcinoma, just because it's the most common salivary gland cancer.
Are these more aggressive than squamous cell carcinoma?
Are these more aggressive than squamous cell carcinoma? Actually, often they are not. Often they are not. Treatment is surgical excision. Carcinomas in general are treated by surgical excision. They don't respond to chemotherapy and radiation as well as some other types of tumors. So surgical excision is usually the primary way we treat them. If we can't get all the margins out, we can use adjunctive radiation therapy, but it's not usually the primary treatment mode. And chemotherapy doesn't usually help at all. So surgical excision with a generous border of normal tissue. 90 to 98% of low-grade tumors are cured. Half or less of high-grade tumors are cured, and we let the pathologist determine the grade histologically. You don't have to know about that. So the only thing I want you to know about prognosis is it's variable in it, and it can vary widely from very bad to very good. So, and it can be difficult to predict. I think I'm going to have to go over. Adenoid cystic carcinoma is one of our salivary gland cancers that's a close second, so you should know about it. Close second to mucoepidermoid carcinoma, and it's the one that's most common in the submandibular gland. It's an important one to know about because it's really difficult to cure. It likes to invade and travel along nerves, so it can get far away from the primary site. And so many patients will have treatment and then it recurs and have more treatment, and in the end they may die of disease 20 years later, but they can live a long time with disease. But it is difficult to treat. And there, you've seen one.
Oh my God.
Does he show signs of malignancy? Yes. Do you notice the facial paralysis? See how he's a little droopy? So when we have parotid tumors that produce a little facial nerve involvement, facial paralysis, that is a sign of malignancy. Our benign tumors in the parotid gland do not produce paralysis. So we had a little paralysis, and he's got a little lumpy, bumpy, weird, firm tumor and some involvement in the tail of the parotid. That one ended up being adenoid cystic carcinoma. They removed it. Now he has some permanent paralysis because they had to sacrifice the facial nerve. Do you see hers? It's in her mouth. Do you see signs of malignancy?
Yes.
It's very red, and it's ulcerated. Are squamous cell carcinomas really, really red like that? They usually have some white in them. So you might have a clue that this is salivary cancer and not oral squamous cell carcinoma. Do you see anything suspicious in this patient? This is the primary tumor right here. Little tiny lump. But do you see the prominent blood vessels way back here? The primary tumor was just a few millimeters. She was treated by hemimaxillectomy, and this tumor had actually already traveled along that major nerve trunk all the way through the foramen and into the brain, even though the primary was just a few millimeters. So this is the one that can travel far, and that's why it's so hard to eradicate. She was a Loma Linda patient. We saw her here. And so it can be a nasty one. 20-year survival rates, 20%. 5 years survival rates, 70%. But total 100% cure is pretty low. And the rest you can read about. This one's important because it has a better prognosis, but you can read about it. And then we're done. So the common ones, the two major ones, are the ones that you should know about for the malignancies. What?
Oh, there is going to be, sorry.
The exam on Monday is going to be half questions on pictures and half written questions. Of the questions on pictures, on cases, at least half of them will be multiple choice. And the remainder will be write-in answers, but absolutely there will be pictures. Yes, it is very important that we assess your clinical diagnostic skills because that's what you're going to be doing in practice. Recognizing things and interpreting them to think about what they could be. Questions?
Then the other half of the questions that are written, those will be like multiple choice?
Yes. So the written questions with no pictures are all multiple choice. You might have a small number of matching. You might have one question with a typed answer, but it wouldn't be more than that. One other thing I need to say about the exam, we're supposed to have it done 24 hours in advance. I can tell you I haven't written the first question yet, and I am not going to make that deadline. But it will be done by the end of the day Sunday, so when you get to school on Monday morning, it will be available to download. You will have plenty of time to download it before the exam starts. There will not be a paper backup because the pictures don't print well enough. You do have to take it on your laptop. If you have any trouble with your laptop over the weekend, first thing, come early on Monday morning and go up to 5th floor and talk to Christina. Actually, she doesn't come until 9 o'clock. After 9 o'clock, talk to Christina in academic affairs because she usually can work out a loaner. But you will absolutely need your laptop to take the exam. Okay? Very good.
Plato quiz.
Want to look at it?
Yeah.
Let me pull it up. Give me just a minute.
Yeah.
Yeah, so
This is huge. 17 inch. Because I do a lot of work at home. I have homework almost every day, and if I don't have the bigger screen, I can't see enough windows like this. If I had upstairs, I have 2 big monitors. If I had that at home, then I wouldn't need a big one, but I don't have that at home, so I have to have this one, and I need it. And it has a full keyboard. And